everybody. We move on to something which is less glamorous than what we've just been through. Today is a very special day because in '91 I did a house job with Professor Tityal, and then my residency was with Professor Ritu Arora, both of whom are present in this room. And I also acknowledge the role of people who molded my thought process in glaucoma. So developmental glaucomas, pediatric glaucomas is actually a very loose term. It includes primary congenital glaucomas, where there is no obvious ocular or systemic anomaly. And then you have the secondary developmental glaucomas, where there is an associated ocular or systemic anomaly. Now, in primary congenital glaucoma, the pathogenesis is at the level of the trabecular meshwork. These children, the three important things to keep in mind for primary congenital glaucoma: the clinical features give us an idea to the line of management and also to the possible prognosis. There's the newborn variety, which is present from birth to 1 month of age, typically bilateral. You'll see this bilateral corneal clouding as you see here. The classical symptoms of blepharospasm, photophobia, and watering are absent. Then you have the infantile variety, where blepharospasm, photophobia, and watering is present. The child typically has watery eyes, closes his eyes in response to bright light. And then the juvenile type of glaucoma, which presents more like the open-angle glaucoma that we see in adults. The clinical presentation for primary congenital glaucoma was first published in the Indian Journal of Ophthalmology in 1983. And it's easy to examine a very small neonate, have the mother feed the child, and you'll be able to do a torchlight examination, get the diagnosis, and then you could proceed on to surgery. The difficulty is in examining an older child because they're crying, they're moving, you can't measure the intraocular pressure, look at the corneal findings. And usually one has to resort to an examination under anesthesia. 1% halothane is normally used, but remember, it's in the deeper plane of anesthesia that the intraocular pressure readings need to be taken. The cornea is a very important diagnostic criteria for us because we're looking for corneal clarity. We are looking for presence of HAB striae, which are typically described as limbus parallel tram track appearance, but they can run through the pupillary area. You may have treated this child well, pressures are controlled, but the resulting astigmatism and amblyopia could limit the visual outcome. So the diagnostic criteria for primary congenital glaucoma: any corneal diameter more than 11 millimeters at birth, 12 millimeters at 1 year, 13 millimeters after 3 years is diagnostic of a primary congenital glaucoma. Remember that the diameter is measured in the horizontal white to white area. Corneal diameter is important for diagnosis. It's also important to assess the response to treatment or surgery because it shouldn't increase after the intraocular pressure has been adequately lowered. Intraocular pressure is not the criteria to diagnose glaucoma in children because the effect of anesthesia and the instrument needs to be kept in mind. So many of these parameters cannot be measured in children. Ultrasonography, again, the length of the eyeball has been used to assess the response to treatment. So again, to summarize, newborn glaucomas present from birth to 1 month, that's 4 weeks. The classical symptoms of blepharospasm, photophobia, and watering is absent. What you see is the bilateral clouding. The infantile variety from 4 weeks to 3 years of age, the child will present with blepharospasm, photophobia, and watering. You examine the child and he turns his head away from you. And the juvenile type is not unlike the open-angle glaucomas that we see in adults. Now, this juvenile type of glaucoma is characterized by presence of open angles on gonioscopy. There are iris processes. There's a high insertion of the iris. You find these prominent iris processes may be in isolation, but there's a thickening of the trabecular meshwork. You could also find heavy pigmentation in the angle. There's a concave insertion of the iris. The juvenile glaucoma is of two types: the familial variety, which tends to run in families, and this is these are 2 generations that you're seeing here operated for glaucoma. The father's father and grandfather also. There's history of blindness amongst all male members apparently from glaucoma. The juvenile variety is also the type which can be present in isolation, and the only characteristic finding could be an iris process as you're seeing here. The juvenile variety of glaucoma is more difficult to treat because patients are in the younger age group, more focused on work, and they don't take care of themselves. So whenever you operate on them, the success rate in juvenile variety is between 50 to 75% over a period of time. They are more prone to incystation because of the bleb, because of faster healing. The blebs thin out and can leak over a period of time. Another form of secondary developmental glaucomas are the encephalotrigeminal angiomatosis, characterized by a facial angioma, as you see here. Often the angioma can be bilateral, and typically when the glaucoma is present, there will be involvement of the ophthalmic division of the trigeminal nerve. The palate can be involved, as you see here. Now the characteristic telangiectatic vessels are a telltale sign. Sometimes they're very obvious. On gonioscopy, there's a thickening of the trabecular meshwork, and often you can see blood in Schlemm's canal. This facial angioma is also associated with a ipsilateral facial hypertrophy, as you see here. Now, the aim is to treat these patients, lower the intraocular pressure medically, failing which you have to resort to a glaucoma surgery. Surgery is difficult and prone to problems like a choroidal effusion on the table. The Sturge-Weber syndrome is a form of encephalotrigeminal angiomatosis when the leptomeninges, the eyes, and the face, all three structures are involved. This was actually a staff nurse. When she came in to show me, my diagnosis was not this, because she had used a good foundation and makeup, and only when she washed her face was I able to pick up this typical lesion. Another child, you can see the angioma, the hard palate is involved, and on the back and the stomach also. So last year we published our results of trabeculotomy, trabeculectomy. That's the combined procedure in 26 eyes of 20 patients. Our criteria for inclusion was a minimum follow-up of 5 years. And just to emphasize that 11 of these 26 eyes needed repeat surgeries over a period of time. So that's just to emphasize the refractory nature of this glaucoma. Another form of secondary developmental glaucoma is aniridia. Typically the word would mean absence of the iris. That usually doesn't happen because there's a small stump of the iris which you can see on gonioscopy. So you can see the absence of the iris. There's just a small stump present here. Often parents have a coloboma of the iris. So if you see a patient with a coloboma, his children are likely to have an aniridia over a period of time. They'll present with this vascular corneal opacities. You can see a posterior subcapsular cataract, subluxation of the natural crystalline lens. Now, when you do the gonioscopy, you'll find a stump of iris, and you'll see this jaw-shaped, shark jaw-shaped projections here. For this reason, the glaucoma usually doesn't present in the first decade, but this stump of iris, as fibrosis happens, goes on to obstruct the trabecular meshwork. So if you see a child with aniridia who presents with a raised intraocular pressure in the early few years of his life, less than 10 years, it's going to be a more refractory form of glaucoma, and these children are going to require early surgery. It's a refractory form of glaucoma, and multiple surgeries are often required. This is one of our patients with aniridia who also had a scleroderma. Another common finding that we see in the pediatric glaucomas is a posterior embryotoxon, which is seen as which is an Axenfield's anomaly. This is how you see it on the gonioscopy, a prominent Schall-based line. And this is called as an Axenfield's anomaly in isolation. The iris can be involved, the typical cat's eye iris, and we use the word Rieger's anomaly. And when it is associated with maxillary hypoplasia and dental changes, the commonly used name now is Axenfeld-Rieger syndrome. Typically, developmental glaucomas have broad-based synecdoche to distinguish them from the goniosynechiae that you see in primary angle closure. So just to show you, the broad-based synecdoche here are suggestive of developmental glaucoma. They don't need a laser iridotomy. Another form of secondary developmental glaucomas are the iridocorneal endothelial syndrome, characterized by a silver beaten appearance to the cornea. You see this progressive essential iris atrophy. The ectopic pupil is seen with the hole formation here. Now, very often these patients are mistaken to have had an acute attack of glaucoma, and this is one such patient who has had multiple iridotomies done to relieve the intraocular pressure. The simplest form is the Chandler's syndrome, where only a corneal edema may be present. And then you have the Cogan-Rees, where these nodules can be seen on the surface of the iris. Just to show you another patient with nodules on the iris. This is some of the patients that we are following up over a period of time. And this is a very interesting patient. We saw him in 2007. See how the progression has happened in 2010, 2014, and he's now beginning to develop cataract changes and needs a glaucoma, cataract surgery. The nevus of Otto, again an oculodermal melanocytosis, is a form of a secondary developmental glaucoma. Pigmentary glaucoma, you see the Krukenberg spindle here is again a secondary developmental glaucoma. You'd label this as a pigment dispersion syndrome or glaucoma. Gonioscopy, you'll see the heavy pigmentation in the angle. And then this is a Peters anomaly. We have 3 or 4 who are following up with us in the clinic, but I've been able to take a picture of only one of these. So again, primary the developmental glaucomas or pediatric glaucomas is a loose term. It includes the primary congenital glaucomas, which are associated with no obvious ocular or systemic anomaly. And then you have the secondary developmental glaucomas where there is an obvious ocular or systemic anomaly. The primary goal is to preserve the vision of these patients, so you got to work quickly, lower the intraocular pressure, and give them appropriate refractive correction so that amblyopia can be prevented. Question is, how do you treat these patients, medically or surgically? Primary congenital glaucoma is a surgical disease, and patients need to be treated surgically. Medical treatment has a role only up to the time that the patient is fit for surgery, because very often these children are very small, and the anesthetist may not allow surgery to be done. But early surgery before the Schlemm's canal gets obliterated. These are some of the surgical options we have. So in goniotomy has been tried and is propagated in the West because their children present to them early, the corneas are clear, and this involves taking an instrument across the anterior chamber to the other side and disinserting the iris. And the requirement for this surgery is a clear cornea. You need to use viscoelastics, and a gonio lens is required along with a surgical microscope. The problem in Indian eyes is that usually present very late, and a goniotomy is not possible. A trabeculotomy has been tried, and they've tried to de-roof Schlemm's canal to get access to the trabecular meshwork. It's been combined with a trabeculectomy, and in Indian eyes, they've tried goniotomy, goniopuncture, Shea's procedure, anterior sclerectomy, and iridontoclysis, but they found that the drop in intraocular pressure was only temporary over a period of time. Now, trabeculotomy combined with the trabeculectomy involves, at the time when you mark your rectangular sclerostomy, at the posterior lip, you give a radial incision to identify Schlemm's canal here, and then cannulate the Schlemm's canal with a Harms trabeculotome passing on to either side. This procedure was found to be very effective in lowering intraocular pressure in the 1980s, and it was reported in the Indian Journal of Ophthalmology way back in 1983. Aqueous drainage devices have also been used in refractory forms of glaucoma, and they perhaps fare better than the primary trab, but the limiting factor is that the complication rate of tubes is higher. Keep in mind the long lifespan of the child. The tube can move and get eroded, and corneal changes can also present over a period of time. So this is an erosion of the tube that you're seeing here. And well-done tube is now beginning to touch the corneal endothelium here. The destructive procedure has also been tried because of the refractory nature of most of these glaucomas, and over a period of time you find this pitting scleral thinning that you're seeing where the diode laser had been done. Often it produces a golf ball-like pitting that you're seeing here. So these are the surgical options. A good option would be easy to do, and obviously one would like to have long-term success rates. So last year we published our long-term outcome of trabeculectomy from a single surgeon. We took 230 eyes of 121 patients. The minimum follow-up in this study was 20 years, and the maximum follow-up we had was 38 years after the initial surgery. And the majority of patients, we found a good success rate. Keep in mind what was said about congenital glaucoma, that once the child develops a congenital glaucoma, you can safely put him into a blind school by the time he comes to adolescence. Now, in this study, we were able to achieve visual impairment actually happened only in about 10% of patients. So by good surgical technique, combining the trabeculectomy, we were able to maintain some functional vision in these patients for their lifetime. In the same study group, we found that 41 of our patients actually needed repeat surgeries. First, another repeat surgery. 16% needed a third surgery. 6 patients needed a repeat surgery. 2 needed a fourth surgery, and only 1 of these patients needed an aqueous drainage implant. So surgery in these children is challenging. The corneal diameter is often large, and this is a patient who had an 18 millimeter corneal diameter where a combined procedure had to be done. There's marked scleral thinning, as you see here, and the anatomical structures are difficult to identify. You can see a widening of the, now this is the anterior axon fields anomaly that you're seeing here, the anterior axon fields embryotoxin. They're prone to incision of the bleb, and these blebs actually thin out over a period of time and leak. So children are difficult to examine, and you ideally need to make the diagnosis at the time of your outpatient examination. That saves the risk of anesthesia, and then you could take up the patient for a surgical procedure. Ophthalmic eyes have low scleral rigidity, and these eyes respond differently on the table. Goniotomy, procedure specific, has been reported as a good procedure, but the limiting factor in Indian eyes is the corneal clouding, because most patients present late. Horizontal corneal diameter needs to be kept in mind. Trabeculectomy is also a viable option when a trab cannot be done. But again, remember, children have exaggerated healing response. Some people have combined this with the use of mitomycin C. Blebs thin out over a period of time and will leak, and that's something you need to keep in mind for children. And perhaps a better procedure is the trabeculotomy ab externo combined with the trabeculectomy, and it involves identifying Schlemm's canal. You could opt for an artificial drainage, an aqueous drainage implant whenever a trabeculectomy is not possible. Now look at the life expectancy of a child who presents today. For each child with congenital glaucoma, you need 3 generations of glaucoma specialists to deal with that child. So keep that in mind. And operating in a child is a little difficult or different as compared to operating on an adult child. So again, the first surgery usually carries the best success rate, but very often these children require more than 1 surgery. So this is a better procedure, combining the trabeculotomy ab externo with the trabeculectomy in children. Destructive procedures continue to be the last resort when there is a poor visual outcome. Now this is a child, you can see the large scleral staphyloma which is forming, ciliary staphylomas which are forming here. Most patients have had multiple surgeries. Just to emphasize the refractory nature of the glaucoma, children need, in addition to surgery, repeated refraction so that the refractive error can be corrected. Good surgery done, not followed by appropriate refractive correction periodically, can limit vision because of an amblyopia. So children, extremely difficult to treat. The first key is to make the right diagnosis and make sure you take the parents and the grandparents into confidence. Go ahead with your IOP lowering treatment, either medically or surgically. Primary congenital glaucomas need to be operated surgically. Thank you very much.